Welcome to the Tobacco Online Policy Seminar TOPS. Thank you for joining us today. I'm Joanne Constantine, a postdoctoral research fellow at the University of Michigan Medical School, Pediatrics Department, Child Health Evaluation and Research Center. TOPS is organized by Mike Pesco at University of Missouri, C. Cheng at The Ohio State University, Michael Dordan at Johns Hopkins University, Jamie Hartman-Boyce at University of Massachusetts Amherst, and Justin White at Boston University. The seminar will be 1 hour with questions from the moderator and discussant. The audience may pose questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your questions are very much appreciated. This presentation is being video recorded and will be made available along with the presentation slides on the TOPS website, tobaccopolicy.org. I will turn the presentation over to today's moderator, Mike Pesco from the University of Missouri, to introduce our speaker.
Today, we continue our winter 2025 season with a single paper presentation by Erfan Loghmani entitled Investigating the Impact of Advertising on Smoking Cessation, the Role of Direct-to-Consumer Prescription Drug Advertising. This presentation was selected via a competitive review process by submission through the TOPS website. Erfan Loghmani is a quantitative marketing PhD student at the University of Washington Foster School of Business. His research interests lie in understanding the effects of interventions and marketing activities with applications in online platforms and the healthcare domain. His aim is to provide policymakers and platform designers with actionable insights and tools to implement impactful and efficient interventions, leveraging methodologies from econometrics and computer science. Dr. Ali Gholi, an assistant professor of marketing at the University of Washington, is the co-author of the study and will answer select questions in the Q&A. Erfan, thank you for presenting for us today.
Thank you, Mike, for having me. Let me go ahead and share my slides for the beginning. Hi, everyone. My name is Erfan, and today I'm going to present this work, which is a joint work with my advisor, Professor Ali Gholi. First of all, I want to thank the TOPS organizers for providing this opportunity and for their awesome feedbacks throughout the selection process. So I know that here we have a multidisciplinary audience coming from different backgrounds. So whenever I'm going to use some marketing language, I will try to explain that at my best, but please feel free to ask any questions if something is not clear. I want to start with this disclosure that basically says that for this project, we don't have any fundings from public, commercial, or nonprofit sectors, and both me and Ali have never got any fundings from tobacco companies or pharmaceutical companies for this project, nor in the past. Today, I'm going to present, first start with some introduction and related literature. Then I will talk about our data sources and so on. So we all know that cigarette smoking is still a significant public health challenge. Sadly, there is 500,000 annual deaths that are directly attributed to tobacco-related illnesses. 500,000. The economic costs are also huge, with more than $200 billion annually. Now, through the years, there have been several smoking cessation products. We have 7 FDA-approved products, 5 of them being nicotine replacement therapies, like nicotine gums and patches. We also have 2 non-nicotine prescription medication, One is Chantix, which is the brand name for substance varenicline, and we have bupropion. We also have another product, which is electronic cigarettes, which is often used by tobacco users as a smoking cessation product. However, this one is not FDA approved, so we look at it at a different category. So our main goal in this research is to study how does advertising smoking cessation products influence consumer behavior and cigarette sales. There are extensive research in clinical domain that look at the clinical efficacy of smoking cessation products in clinical trials, for example, comparing the efficacy of different products. However, in this research, we are looking at the effects of advertising these products rather than just using them. So why we're looking at advertising, to give you a bit of context from the medical literature, there is this consensus that prescription drugs are generally more effective than over-the-counter options. But from the advertising point, because these products have different access, for example, if someone wants to get the prescription drug, they should go to their doctor, get the prescription, and then fill the prescription. But for over-the-counter options, they can easily go to their local supermarkets or pharmacies to get them. Because of this different access, this is one important thing that differentiates these products. Also, these products could act both as complements. For example, we can have co-prescription of NRTs and prescription drugs, or they can play roles as substitutes when consumers opt for more easily accessible options that are NRTs instead of going to get the prescriptions. Because of these spillover, substitution, and complementary effects, this is a complex situation that we want to study further in this project. I want to now give you some examples of what could be the effects of different advertising. So direct-to-consumer advertising for prescription drugs can reduce the cigarette consumption for people who can access through prescriptions. However, because of barriers like not having good insurance coverage or prescription requirements, it can push consumers to go for more easier accessible products. On the other hand, advertising for NRTs, while they're promoting one type of cessation aid, it might reduce the likelihood of seeking more effective prescription options. In this research, our main research question is how does advertising for various smoking cessation products affect consumer demand? We find that direct-to-consumer advertising of prescription drugs is actually the most effective in reducing cigarette sales. And we find various spillover effects beyond the advertised product that I will talk about more throughout the talk. Our next question is, what is the role of insurance coverage on this advertising effectiveness? Our approach to answer these questions is to combine claims, retails, and advertising and data. So we basically have lots of data sources that I will talk about from a long period for 2011 to 2019. Before starting, I want to talk about different categories of products that we're going to look at. We have cigarettes that are traditional combustible cigarettes. We have electronic nicotine delivery systems, which are electronic cigarettes, vapes, or cartridges. We have nicotine replacement therapies and prescription drugs, which we have these two forms of prescription drugs. Now I want to also talk and highlight which one of these categories can advertise. We know that from ban in 1971, cigarettes cannot advertise, but other products can legally are allowed to advertise on television. and we are going to look at the advertising for these categories. This is how our research connects to previous research. It is just an illustrative list of literature. There are lots of studies. Our research directly connects to tobacco marketing, direct-to-consumer advertising, and advertising spillover effects. In the tobacco marketing, there are previous research that look at the effect of certain types of advertising. For example, this one looks at NRT advertising and public service announcements in magazines. And one other one is this Anat Loghmani paper that focuses on e-cigarette advertising. In this project, we are gonna take a more comprehensive approach by looking at different categories of products. Next, our research connects to direct-to-consumer advertising for prescription drugs. While there are research that shows the effect of these advertising on different consumer behavior and healthcare outcomes, like adherence to drugs, our research looking at this specific category with both over-the-counter options and prescription drugs adds to this domain by looking at this certain situation where we have both types of things. And lastly, our research connects to advertising spillover effects by looking at this domain with its specific characteristics. With this introduction and related literature, I want to now go and talk about our data. We use data for 9 years from 2011 to 2019, and these are the lists of our data sources. Basically, we have data on advertising, detailing retail sales, claims, and insurance coverage. With the advertising data being the heart of our project, I want to take more time and describe what this data looks like. So for example, you're sitting and watching your television and you're watching a news channel and you see one advertising for a certain brand. So this is, we call an advertising occurrence. And also in the United States, there are 210 geographic areas which are called designated market areas, which can show different advertising, and our data has the impressions at these DMA levels. Out of the 210, there are 131 of them that have full list of the occurrences, so they are a less noisy sample that we are going to focus on these. And basically, we have impression estimates at the occurrence DMA level. Let me talk also about the advertisers side. Advertisers can either purchase ads at the national level or more narrowly at the local level, which is called a spot. So while I'm here with the map, I want to get ahead of myself and talk a little bit about our empirical identification approach. So there are two forms of identification. One is the border method strategy, which looks at the bordering areas of the DMAs. The assumption there is that looking at the counties at the border, the things in the two sides of the border should be the same, and the only thing that's different is the advertising exposure. So it focuses on that and takes that for quasi inference. However, this method, using only the border areas, it will capture local average treatment effects. There's also another way which uses the whole DMAs and uses fixed effects to absorb the effect of compounds. In this research, we have both of the results, but we are going to use the second one, which has all of the areas as our main results. So our advertising data, as I said, is at our current DMA level, and we aggregate this to get a measure which is called gross rating points. which is basically the share of the DMAs, the share of the households that have watched certain category of advertisement. This table shows some summary statistics of our advertising data. I want to highlight that prescription drugs is one of the major players in this area that has the highest advertising. Then we have NRTs and PSAs and e-cigarettes. So this table again shows the importance of prescription drug, which is often not studied in the literature. Let's talk about our retail and healthcare outcomes real quick. We're looking for retail data, which comes from Nielsen Retail Measurement Service. This data has prices, quantity sold, feature, and display at the UPC week level. So these are some marketing language. So the UPC is basically an identifier for each product. The feature is whether the product have run an advertising in the local store outlets or flyers. And the display is basically whether the product is featured in certain special places in the store to grab more eye attention. From this data, we're going to look at three categories, which are cigarette sales, e-cigarette sales, and over-the-counter NRT sales. For the healthcare outcomes, we use Merative market scan data, which has individual level medical records on prescribed medicine and outpatient visits. This data is aggregated at MSA level, so we should align it with our DMA level data. And for this data, we look at the number of prescriptions and the number of outpatient visits for mental health and substance abuse. With this introduction and data, I think it is a good time to pause and see if there are any questions that I can answer.
Okay, thank you so much, Erfan, for a very interesting presentation so far. Audience members, if you have questions, please place those questions in the Q&A panel, and we'll get to those momentarily. But first, I'll turn it over to our discussant today. Our discussant is Dr. Jim Flynn, a health economist and an assistant professor of economics at Miami University in Oxford, Ohio.
Yeah, thanks. Thanks, Mike. So I think I want to just start by spending a moment just kind of gushing about how much I like this paper. I think I also just want to say like how much I appreciate getting the chance to be here and talk about it. So this is a really welcome analysis to this literature that makes a number of, I think, really important contributions. I think you do a good job of claiming a lot of those contributions. I think there's actually some room for you to maybe be a little bit more forceful in claiming about some of the other ones. That I think I'll talk a little bit more about that after results as we get into them a little bit more. But this is a really interesting paper that addresses this gap, right, in how to get people, one, aware of and actually to engage with and use prescription drugs. There's this disconnect between getting phase 3 clinical trials done and getting drugs approved, and then actually getting them to become a mainstream part of people's lives, something that the people engage with and use on a regular basis. And this paper really shows that there's this important channel for direct-to-consumer advertising to play. I think I will admit to coming in to reading this paper with a fair degree of skepticism about how good direct-to-consumer advertising for pharmaceuticals is. But this, I think, substantially moved my priors sort of in that direction to show that there is a real benefit in using it to let consumers know about this great option that has the potential to really improve people's lives. Also, you leverage this just amazing preponderance of data from all of these different sources to really like fully trace out the impacts of direct-to-consumer advertising in this market. That's all just really interesting. So I think just overall, I really appreciate the detail and the rigor with which you've conducted this analysis. I think in reading the paper, probably my biggest concern or biggest question is thinking about the potential endogeneity of ad placements. And I know it's actually the next slide. I realize that I think you're going to talk about it. But I think the biggest question that I'd like to get you to maybe chat about a little bit more is like, what, if anything, do we know about how advertisers are making the decisions of where to place ads, right? You definitely address the possibility of this endogeneity, and also I think you have this other border strategy, which is great. But that's the question that I have no idea about, right? Like how do the advertisers make these kinds of decisions, and what if anything do we know about it?
Mm-hmm. That's a very good question that I'm going to talk about more in the upcoming slides. But basically, to give some points, first of all, most of the advertising decisions are made in an upfront market, which advertisers could basically purchase their ads for the year upfront, which takes about 80% of the advertising. So in this sense, they have very limited targeting capabilities, like they should do decisions early on in the year. And the rest is sold throughout the scatter market, which usually comes at the higher price. I'm not sure whether it's good to maybe show the slides while we are here. And because most of the decisions are either taken annually and quarterly, and we have fixed effects that take out the annual decisions like out, we think that we are accounting for most of this. Now that I'm here, I also had a background like an appendix to talk about this more. I think it's maybe a good time to also talk about this. So basically the concern is if sorry, if we have some endogeneity happening, one thing to show that is that we could have correlation between different forms of advertising. This is in fact seen in our data that NRT and Chantix advertising are correlated. However, when we apply our fixed effect, we see that this correlation goes away. So this is, here we are looking at a yearly DMA correlation between these types of ads, and we are plotting the distribution, which at the beginning shows a positive correlation. But with the fixed effects, we can take out most of the compounds.
Erfan, can I add something just here to James' point? I think, James, absolutely, you're right. There is a concern that, can you go back to the figure? There's a concern that, there's endogeneity going on. You have some form of targeting, and obviously they do target. Most of the targeting is based on predictable seasonal patterns. I can advertise a little bit more earlier in January rather than January of 2019 versus January of 2018. There's those week of the year fixed effect that take that out. Now, to show evidence that these folks are actually smart, there are two players that advertise a lot. There's NRTs and there's Chantix. If you actually do the correlation between advertising at DMA year level of Chantix and NRTs, that gives you the left figure. It seems like they are going for those demand shocks, and you get a positive correlation. Now, if you take the residual variation, that largely moves away, and we're using week-to-week variation exposure to advertising. So I think that's the argument that Erfan is making here.
Yeah, thanks. That's really helpful. Yeah, and I do think, right, you utilize like a lot of approaches in your data to get around this as much as you can. Yeah, I think that is the biggest thing that I kept thinking about coming back. But I do think you do a great job looking into that. I don't know if we want to get to if there's audience questions. I have a couple more like smaller, not nitpicky. I think more just like things that that struck me as interesting pieces. But I don't know if we want to get some audience questions.
Well, maybe we can move on and let's save some of the questions for maybe the next segment.
Yeah, great.
So your co-author Ali's been doing a great job answering Q&A questions. I think that we will leave Q&A alone for now, and you can move on with your presentation.
Okay. Yeah, and one other thing I want to add to the James comments, like he said that finding that direct-to-consumer advertising is effective was interesting. That was also our story and during the research, we started with looking at the effect of public service announcements, but then when analyzing the data, we found that actually these direct-to-consumer advertising for prescription drugs are the most effective. So that was a bit of the story behind the project. Now I want to continue the presentation with talking about our empirical approach. We already talked about this a little. So we're going to use the geographic variation in occurrences and impression of ads to estimate the causal effects. And as James mentioned, there are endogeneity concerns. Firms can advertise more in markets where they expect more lift, like a lift is a measure of effectiveness of the advertising. And there could be also spurious correlations like with a seasonality or like certain times that could go into our estimates that we should be aware of and handle them. So our identification uses this coarse targeting that I already talked about. We also have used the sampling frequency. Our data is aggregated at the weekly level, but the decisions are made annually or quarterly. So this is another place because having a more sampling frequency than when the decisions are made, we can use this variation. And lastly, we have high dimensional fixed effects to absorb the effect of compounds. As I said, we have robustness checks with using different method, which is the border method strategy. And when applicable, we use placebo regressions to show that the effects are actually limited to our relevant outcomes. So here is our estimation specification. On the left, we have our outcome of interest, which for the healthcare outcomes, it could be the number of prescriptions or number of visits. On the right, for advertising, we are using this measure, which is a long-run measure of ad exposure that discounts the earlier times with this exponential decay multiplier, and we are using the GRPs to weight the past times. And we also have fixed effects. We have market year fixed effects to account for differences through the market years, and we have fixed effects to account for seasonality and general trends as well. So let's go ahead and talk about the results. Because in our healthcare data, we have 15% of observations being zero, and maybe the log-log method might have challenges with the zeros. We also show Poisson results here. So this table shows the effect of advertising on prescription drugs demand. We see that on the rows, we have coefficients for each type of advertising, and on the left, we have the effects on varenicline and bupropion. Again, I want to remind that varenicline is a substance name for Chantix. So here we see that the direct effect of Chantix advertising on varenicline is positive and significant, which shows that we have this significant direct effect. We also see category expansion of Chantix ads to other prescription drugs, which here is bupropion. One other thing that we observe from this table is that nicotine replacement therapy advertising actually reduces prescription drugs use, which could be more effective, as I talked about earlier. We also look at the effect of advertising on office visits. Here we see that Chantix ads are also affecting office visits that are not directly tied with a prescription. So we are taking out the visits that have one prescription immediately after them. So these are the effects, like just by seeing the ad, if I'm more likely to visit a doctor or not. And we see that these ads actually encourage individuals to seek professional healthcare support. We also have some placebo results that only looks at emergency visits for mental health and substance abuse, which shows that the effects are not significant there, which again shows that our results are only related to the relevant outcomes. Moving on to our retail sales specification, we have basically the same thing, but we are adding the prices and other marketing variables as controls here. This table shows the results on our retail data. We see that Chantix ads show clear evidence of reducing cigarette sales, and basically other forms of ads are not as much effective. We also see that e-cigarettes play an important role with Chantix advertising and public service announcements increasing the usage of cigarette, which shows that probably tobacco users see e-cigarettes as an alternative when they want to seek to quit. Lastly, for the over-the-counter NRTs, we see near zero effect. However, in the earlier results, we see that NRTs and Chantix could play substitutional effects between each other. However, here, this substitution effect could be lower because we could also have category expansion for individuals that don't have insurance access, which I will talk about more and show more evidence of this in the upcoming slides. So up to now, I talked about our main results that are direct effects of advertising. Next, I want to talk about the role of insurance, but I think here is also a good place to ask for questions.
That's great. So yeah, again, I'll turn it over to our discussant, Jim Flynn.
Yeah, great. Thank you. So this is kind of what I was alluding to the last time. So so you mentioned a number of great contributions that you're making here. To me, I think one of the most interesting ones is that you're showing real evidence that Chantix is very successful in real world applications, right? So we know that it's really good in clinical trials, like it passed those with flying colors, and that's great. But there's this huge cry between, is a drug useful in a clinical trial setting where it's closely monitored, where people are getting reminders, versus when people are actually getting it, and purchasing it and taking it in the real world. And this is showing, like, so I did do the quick, like, if we're thinking about making an IV estimate here, like scaling the reduced form by the first stage, you're getting an estimate of like a 40% reduction here in cigarette purchases, which is huge. That's saying that this drug is incredibly effective. And I think that's an important contribution that you're making. And I think you describe it, or you're talking about it, but I think it's actually up there with one of the more important things that's coming out of this, right? Like you're really showing that in the real world, when people are induced into using this drug, it makes a big difference in their outcomes. And that's really encouraging, just to me as someone who cares about this, but also I think is important and maybe worth highlighting a little bit more aggressively in the paper. So yeah, I also think it's worth exploring the dynamics of that a little bit more. Like that actually might even be another paper to write on top of this, is sort of understanding how and why and exactly like in what settings the drug is so effective, because I think you have the data to be able to do that and to have it be pretty well causally identified because of this, this strategy that you're using. So I think that's really cool. I have two, I guess, more minor suggestions. And this maybe depends on where you are planning to submit it. Like if this was to a health economics journal, I wouldn't suggest leading with like the log X plus 1 specifications, as I think those are going to receive a lot of pushback from economists. I don't know where you're planning to and what the norms are in that literature. It makes perfect sense why you're choosing to use it, right? You have a lot of zeros. You want to have this kind of elasticity interpretation. So I get using it. I'd suggest either leading with the Poisson or possibly trying another one of these transformations like the inverse hyperbolic sine or even square root that try to do some of the similar things that don't explicitly do that. But that's sort of for you to decide and where you're sending it to. And then in thinking about office visits, one thing, it makes sense, your strategy of excluding everyone who's ever going to use Shantix to try and get an idea of other office visits. My concern with that is how correlated that might be with opioid visits, which are spiking sort of throughout this period. And so I think in some way to try to address that potential elephant in the room, I think would be really valuable.
Got it. Yeah, to talk about the points you mentioned, first of all, I also personally like this thing that the prescription drugs are effective. And as you said, like this shows the effectiveness of going and having some more support because when you go and get some NRTs, then you're on your own. And maybe that's the reason why we're not getting more significant effects on that. Yeah, about the log specification, that's also one thing we faced in our revisions. And as you say, there are problems with the log in areas where we have lots of zeros. So that's why we also put Poisson for our earlier results. But actually in our results and retail sales, because it's at the store level and we have a very limited zeros, we're using the log, which gives us the elasticity estimate. But that was a good one that, as I said, we're also working on in our revisions. So let me understand your concern about the opioid one. So you're thinking that Chantix advertisings are also increasing the opioid visits, and we're somehow capturing that. Is that correct?
No, I'm much more worried about it as a confounder. I mean, one, I think if we just looked at the raw correlation between, where smoking addiction is a problem and where the opioid crisis has hit harder, there's going to be some correlation there. So the areas that are being advertised to by Shantix are also probably ones that are being hit by the opioid crisis. And so something you might be picking that up. I'm not exactly sure how to address that, but I think it merits some discussion, just because I think how much visits for opioid are probably like spiking throughout this period. I think at least some discussion in some way to maybe try to control or different. I could be wrong about that prior, thinking that there's going to be this correlation there, but I do think that some mention, some addressing of it, or maybe some way to control for the levels of opioid abuse taking place in these different marketing areas, I think is probably worthwhile.
I see. Yeah, that's a very good suggestion. I would say perhaps some of those would go into our market here fixed effects, but still, I'm also interested in the opioid area, and I will take a note to look at that data and see whether there are correlations that still could go into our specification. That's
So
very good.
Erfan, I think your placebo on emergency visits a little bit speaks to that. If there is worry that, generally occurrence of substance abuse is higher in some certain area, that would co-move very well with emergency visits in general, right? So
Sure,
and then you don't get any effects there. So I think I think you have to investigate this directly head on, but emergency visits have a good relationship with underlying issues in different geographic areas, and you don't get that, and it's for planned office visits that you get the effect. So that a little bit speaks to that, doesn't fully address it. But I
Yeah,
think,
no, it's a great point.
yeah.
Yeah, that was a very good point because perhaps opioid problems are also related to the emergency visit. Thank you, Ali. And I think the suggestion to put more discussion in the paper is also a good one to answer these questions before. Thank you, James. Any other questions, or should I move on?
I think that, yeah, I think that it's okay to move on at this point, and people can keep adding questions in the Q&A. Your co-author's doing a great job of answering those. Thank you.
Thank you. So our takeaways so far, we saw that direct consumer advertising for prescription drugs has effects both on retail sales of cigarettes, e-cigarettes, and NRTs. And we also observed effects on prescription drug use and office visits. So the next question is, how much does the easyability of access or access barriers to this like prescription drugs or office visits affect the effectiveness of advertising? So it was very good if we had a variation in our data here so that we can see the effects across different populations with variation in their access. However, because our insurance coverage data comes from Merative, which basically has data for only the individuals who have insurance access, we cannot address that in our healthcare data. However, we look at our retail sales data and look at the geographic differences in insurance access to see effects on how does insurance access plays a role in this area. So as I said, we're going to use the geographic variation on insurance coverage, and we use public use microdata sample to get yearly estimates of this. So we create estimates for the access level to our insulin through insurance, and we also construct other demographic variables. So our specification would look like this, where we are interacting our Chantix advertising coefficient with these like z-scored values of these other estimates, which we have interactions with coverage, also provider per capita, like how easy is to measure how easy is to get to a provider, and we also have these other demographic variables. So these are our results for this heterogeneous effect. We see that Chantix advertising has more effect on reducing cigarette sales in areas that have better coverage, and it's easier to go and see the doctor because there are more providers per capita. So this shows that insurance and easeability being easier to access the provider is in fact playing a role. We also see that in areas with more insurance coverage, the spillover to NRTs is lower. And we see that this is in fact true for both e-cigarettes and over-the-counter options. Now I want to show this story, which these results show that perhaps the users, when they're faced with Chantix advertising that encourages them to go and get the prescriptions, they're like, no, we can go and get more easily available over-the-counter options. Yes, so perhaps it could be the story here, but basically these results show that while the over-the-counter NRT coefficient, the base is 0, this difference in geographic areas could explain that in some areas that have less coverage, we see that this spillover more. With this results, I want to now go ahead and wrap up. So what are the implications of our study? There are some debates on limiting direct-to-consumer advertising for prescription drugs, and our results directly speaks to this debate. For that, we evaluate the response to a hypothetical 10% reduction for smoking cessation in the last year of our period. We find that this 10% reduction increases cigarette consumption by about 23 million additional packs. At the same time, because direct-to-consumer advertising had a spillover to other things, we see a decrease in e-cigarette consumption. But overall, these two, when aggregating them, comes to a net effect of nicotine intake of 21 million packs of cigarettes when we translate this e-cigarette usage to its relevant number of cigarette packs. So overall, this results show that direct-to-consumer advertising for this certain category is useful and adds to that debate. In this talk, we saw that direct-to-consumer is the only type of advertising with clear evidence of effectiveness. We also found that these ads have spillover effects to over-the-counter options. We saw that this spillover is actually variable in terms of insurance access and access to prescriptions. And we finally showed the potential risk of advertising bans in this category. With that, I want to thank you again to the organizers and for your attention. Here is the link to the paper. If you have any comments, feel free to reach out to me or Ali. Thank you.
Thank you, Erfan. And just as a reminder, if you're interested in continuing the discussion with the speaker, with mics enabled, you're welcome to attend Top of the Tops immediately following the webinar. If interested, please copy the meeting room URL posted in the chat now so that you will be ready to join the live discussion once the webinar concludes. And I'll turn it over to Jim for any further discussion comments.
I think you're
muted.
I almost successfully made it through this without messing that up. I don't have any major like substantive additional comments. I think the insurance piece I think is a nice addition. I think that's interesting how the over-the-counter elasticity sort of works there, and that it creates a little bit more substitution as there's more insurance coverage. But I think my main substantive comments, I think I already got out there. So I think I just want to say, yeah, I think this is a really nice paper. Congratulations on it.
Yeah, thank you. And one thing I think I missed from the previous time is your suggestion on the dynamics of the problem. I think that's also a very cool thing to look at. Unfortunately, we can't do that on our retail data because we don't have individual level data there, but can definitely do that with our medical data and look at their office visits or their prescription intakes to have more intuitions about the dynamics of the problem. Actually, I think we have some results on the prescription adherence that I'm not sure if it's in the appendix of this version or we have not yet added that, but that says that we don't see an effect of advertising on prescription adherence for Chantix advertising. However, in that result, we see that NRT ads increase the Chantix adherence, which we think because NRT ads take away some population of Chantix users from our data that could that are maybe less adherent to the drug use. So removing them would increase the average for the people who start their prescription after.
Right. So, sorry, so you're saying that that Chantix advertising doesn't change like the likelihood of adhering to the prescription guidelines of medication users?
I'm not the likelihood, but the length, like the average length of adherence, like how many weeks you're gonna continue your drug usage if you start after times which have more advertising.
Yeah, I think like that null finding is actually quite interesting on its own, right? Because the concern would be that the advertising is going to get in a bunch of marginal folks who wouldn't be as successful with it. But this actually suggests that's not the case, right? That it's likely to still be just as successful as them. So that's also very cool.
So just to add here, it's right for Shantex that the marginal consumer is not the bad type of consumer. But when NRTs advertise, the marginal consumer they take away from Shantex, there would be some people who they steal from Shantex.
Yeah.
Those are the people who are less adherent. I think that's what Erfan was saying. So the people who move away from direct-to-consumer advertising from prescription drugs to over-the-counter options, those are less adherent. I think that's what the result speaks to. So
very cool.
Thank you for your comments.
So I had one question for you. So I think that your if I'm interpreting it correctly, your results for the effect of e-cigarette advertising on cigarettes, would you mind backing up to that?
Sure.
So I think that these differ a little bit from what Anna Tuckman found. Is that correct? Because I thought that she found e-cigarette advertising had an effect on cigarette sales. And I was just wondering if you could just elaborate a little bit more on if there's actually a difference here, and if so, why?
Sure. Yeah, that's one thing we have put some thought about. That's why we're getting this different result. But actually, when you go to, I think it's because of we're using different measure of advertising than the main results in Anna Tuckman paper. Actually, if you go to the appendix, I think it's their appendix F, which shows that if you use different carryover effects, the results change. And when they use the same carryover effect of advertising exposure, their results are same with us, not getting like long-term effects of advertising. So basically, it's comparing the short-term versus long-term, which our results align with what she has in the appendix.
Okay, great. And one other question, could you tell us a little bit more about the market scan data that you use? Like how many beneficiaries is that capturing? What kind of health plans are these people in? How is there a good geographical dispersion of people across the different MSAs?
Yeah, that's a good question. So that data only covers individuals that are covered with private insurance coverage. So these are people who perhaps have better insurance coverages than other people. If I have it correctly on top of my mind, there are about 20 or 30 million people across the United States. So I would say it is a very rich data set to look at. And we also have some other ideas to look further into that data, because that also has some demographics on the age and gender of the individuals that we can we want to take further look into that as well.
Is there any benefit of this data over the Healthcare Costs Institute? I mean, that's the commercial claims data source that I'm most familiar with. How does Market Scan, like how does it stack up with HCCI, and how is it different?
So I actually haven't looked at that. I'm not sure if we have access to that or not, but I think based on your description, it should be the same, like if it has the claims data, but I'm not sure about the comparison and the size.
Okay. All right. Well, thanks again for a very interesting presentation. I think I'm going to turn it over to our MC to take us out the door. And just as a reminder, if people want to keep the conversation going, please join Top of the Tops.
Thank you, everyone.
We are out of time. However, if you still have burning questions or thoughts for Erfan Loghmani, you can join us for Top of the Tops, an interactive group discussion. To join, please copy the Zoom meeting room URL posted in the chat and switch rooms with us once this event concludes. We will leave this webinar room open for an extra minute after the end to give everyone a chance to copy the URL, which is bit.ly/topsmeeting, all lowercase. Thank you to our presenter, moderator, and discussant. Finally, thank you to the audience of 144 people for your participation. Have a top-notch weekend.